Hello all, the topic of discussion will be on aggressive periodontitis. Periodontitis is the pathological manifestation of host response against bacterial challenge, etiology being the same but differs in clinical phenotype. Aggressive periodontitis is a rare, severe form of periodontitis characterized by early onset of clinical manifestation and often tend to run in families. Coming to the history, in 1923, Gottlieb reported the diffuse atrophy of bone. He also suggested deep cementopathia in 1928, where there was inhibition of cementum formation. Then in 1938, Vanenmacher suggested the incisor molar involvement. In 1966, in the World Workshop of Periodontics, it was called periodontosis. In 1967 and in 1969, it was called juvenile periodontitis. In 1971, Bayer gave a definition for the disease as the disease of periodontium, which occurs in otherwise healthy adolescent, which is characterized by rapid loss of alveolar bone, about more than one tooth in permanent dentition. Then in 1989, Page and Barb suggested the term localized aggressive periodontitis from localized juvenile periodontitis. Later in 1999, American Academy of Periodontics suggested a consensus report saying it as the aggressive periodontitis. So how it differs from chronic periodontitis is with the onset of age, disease progression, nature and composition of microflora, alteration of immune response and familial aggregation. So Bayer not only gave the definition but certain criteria to be accepted as aggressive periodontitis. They are circumpubertal age, that is from 11 to 30 years, bone loss pattern, rapid rate of disease progression, disease involving permanent dentition, local factors inconsistent with destruction, female to male ratio as 3:1 and familial pattern. Coming to the clinical characteristics is the clinically healthy gingivitis except for the periodontitis, then rapid attachment loss and bone loss, familial aggregation, microbial deposition inconsistent with periodontal destruction, increase in actinomycetum comitans and porphyromonas gingivalis, phagocyte abnormalities, and hyporesponsive macrophage phenotype, increase in the levels of PGE2 and interleukin 1 beta. For both localized and aggressive periodontitis, there are similar features, but few features are exclusively for local and generalized type. For the localized involvement of the teeth, why it is said as localized is because the first erupting permanent teeth in the oral cavity is being involved, that is the incisors and the molars. Then in generalized aggressive periodontitis, it is the loss of attachment of at least 3 permanent teeth other than first molar and incisors. So it is kind of generalized and it is often associated with systemic disease. It will manifest as a normal gingiva having a deep pocket, also an acutely inflamed proliferating fiery red ulcerated gingiva with suppuration. So coming to the radiographic features, the localized aggressive periodontitis will have a vertical arch-shaped bone loss in first molar and incisors, wherein generalized we can find a severe bone loss associated with minimal number of teeth followed by majority of teeth on progression. Coming to the causative organisms, they are Porphyromonas gingivalis, Prevotella intermedia, Tannerella forsythia, Campylobacter rectus, Echinella corrodens, Fusobacterium nucleatum, Actinomycetum comitans, Peptostreptococcus micros, Treponema denticola and Eubacterium species. So what are the risk factors? Is that microbial factors where Actinomycetum comitans was present in all of the investigations present. Immunological factors where markers for Actinomycetum comitans turned positive. Genetic factors where familial clustering of neutrophil occurred, and in environmental factors along with the periodontitis, if at all smoking is there, then the symptoms would increase. Coming to the management of aggressive periodontitis, why should we manage? It's better to manage with early diagnosis, prevent further destruction than regenerating further. then for finding in initial radiographs, then the patient education and risk factors. So how will we manage it? By non-surgical periodontal therapy, antimicrobial therapy, full mouth disinfection, hose modulation, regenerative therapy if it's going advanced, then periodontal maintenance. Thank you.